So hello, everyone. It's really a great honor to introduce Paul Bunn as today's Cancer Center speaker. I brought a CD, but I'm not going to actually go through it. I'll just say a few things. So first off, I can really think of no one, and I really mean this, who has had a greater impact on cancer research on this campus, and probably in all of Colorado. So about 30 years ago, Paul Bunn submitted and became the first director of our cancer center. So essentially establishing the cancer center here. And about 6 years later, he submitted and got funded the lung cancer SPORE, which has been pretty much continuously funded ever since. So he's had for decades just an enormous impact on this campus. And while I could read you the dozens of honors, I think the two that are up there are pretty good. He's a distinguished professor here. And there aren't a whole lot of distinguished professors, so that tells you how distinguished it actually is. He's also the James Dudley Chair for Cancer Research. But I think the most important thing is that Paul is incredibly generous with his time, and I think that's been impacted on the incredible number of mentees that he has developed and led into cancer research. He's generous when it comes to publications, collaborations. It's really that collaborative spirit that has made this place such a good place to do cancer research. And Paul really has not only embodied it, but he's really catalyzed it. And I consider myself one of those mentees. And he's also just got this just absolute passion for doing something good about cancer. Not good for cancer, but good for cancer patients. And I think he's really accomplished that. And his impact has been just enormous, particularly in the area of lung cancer. So without further ado, I'd like to introduce Paul.
Is it on now? So the good news and the bad news is on this slide, just to start things off. The red line on the top is lung cancer mortality in U.S. males, and the red line on the bottom is U.S. mortality in U.S. females. And you can see the bad news is that both red lines are much higher than any other line. And the good news is that the red lines are both going down. So lung cancer is by far the leading cause of cancer mortality in U.S. men and in U.S. women. But fortunately, primarily due to research efforts, mortality rates are declining. And usually people thank all the people that helped them at the end. But I'll just thank the people that helped the research that I've done here in the beginning. So this is what's in red is what I'm going to talk about today. And we're just talking about cancer treatment today. So the first question is, for a lung cancer patient, how do you determine what treatments there are and what treatments would be best? And not surprisingly, those include the performance status of the patient. That is, what kind of condition is the patient in? If the patient can't get out of bed, the patient may not benefit from chemotherapy because it might kill them before it could benefit them. And then, as you can see from this slide, we treat different histologies different. Adenocarcinomas are treated differently from squamous cancers, which are treated differently from large cell neuroendocrine lung cancers. So we have to know the performance status, the histology, and then we have to know whether the tumor cells express any inhibitory immune proteins, PD-L1, for example, and we have to know whether the tumor has any molecular driver alterations. So today we're going to be talking about molecular therapy, that is, patients with molecular drivers, and patients who have a very high immune protein on their cell surface. So the patients with a molecular driver get treated with a pill, an oral tyrosine kinase inhibitor. And which one of those tyrosine kinase inhibitors they get depends on which molecular alteration they have. And they continue on that treatment through what we call maintenance until they progress. When they progress, most of the time, but not always, they have a change in their molecular driver and can get another oral tyrosine kinase inhibitor. The ones that have high expression of an immune protein, PD-L1, in the first line get treated with an immune antibody, in this case pembrolizumab, and they stay on that for 2 years or until they progress, and then they get standard chemotherapy. So why is that? So we're going to start with molecular therapy. Dr. Franklin, who's sitting in the front row looking at his cell phone, observed that in your bronchial epithelium, you have in your basal layer, that's the layer that divides and replenishes the epithelium, you have lots of protein for epidermal growth factor receptor. In fact, EGF and TGF-alpha that bind to that receptor are responsible for replacing the cells in your bronchial epithelium. But he noted before you get cancer in the presence of carcinogens, the epithelium gets thicker and the epidermal growth factor receptor is not just in the basal layer anymore, it's distributed throughout the epithelium. And he and others noted that cancers frequently expressed the EGF receptor. So pharmaceutical companies made some tyrosine kinase inhibitors that bind to the EGF receptor, and people thought that these were going to be great because since 80% of the cancers overexpressed EGFR, they thought these treatments would be great for a large majority of patients. And in the very first trials, just the phase 1 trials, these were conducted in 2000, only 10% of the patients had an objective response, but they were frequently dramatic and they frequently lasted a long time, longer than chemotherapy. Now, in the great enthusiasm for this, companies just took standard chemotherapy and without looking at receptor expression, randomized people to get standard chemotherapy or standard chemotherapy plus one of these pills. And the trials were completely negative, as you can see in the slide. However, fortunately, there were some smart people in Boston that looked at that 10% of patients that had a great response, and they said, what's different about these patients? And so they sequenced the EGF receptor gene. And lo and behold, they found mutations in the EGF receptor gene, shown here, this G719 and the L858R. And what those did was they changed the structure of the ATP binding site of the tyrosine kinase domain such that ATP, which would ordinarily not bind, when the mutation was there, the ATP binding site was opened, ATP was always binding and signaling growth and anti-apoptosis, and so you got cancer. And those drugs, those pills, erlotinib and gefitinib, bound into the ATP binding site, so ATP couldn't bind. So that was the first evidence that you should try these treatments in people with an EGFR mutation. And after that, there was a large number of clinical trials, shown here, conducted in the US, Asia, and Europe, that compared 3 different EGFR TKIs to chemotherapy as the first treatment. This is the response rate, and the first column is the response rate to the TKI, which you can see is very much higher than the response rate to chemotherapy. And the duration of that response, the progression-free survival, was also very much longer with the oral tyrosine kinase inhibitor than with chemotherapy. And the toxicity of the tyrosine kinase inhibitors, and people stay on them for years, was much less. Interestingly, though, in these trials, patients were, after they got chemotherapy, allowed to cross over and get the tyrosine kinase inhibitor. So none of these trials had a statistically significant difference in survival, even though the belief was patients were living longer. Now, to put that into a more generalized setting, this institution, the University of Colorado, led a NCI grant funding the Lung Cancer Mutation Consortium that looked at consecutive patients with adenocarcinoma of the lung that came in the door and sequenced them to see what molecular drivers they would have, and if they had a molecular driver, to put them on a trial. And you can see this slice of the pie, the EGFR molecular abnormalities, was second most common after KRAS. And if you had a molecular driver and you got a molecular pill, this was the median survival. And if you had such a driver but didn't get any treatment, the survival was much less. So even though those trials didn't show an advantage because of crossover, if you had a driver and didn't get treatment, your prognosis was much worse. Now, one of the things patients want to know, of course, is how long am I going to live? And they look at those data, and you can see that the median time to getting worse in these trials is about 10 months. But some of the patients do better. In fact, this is a study that was done with gefitinib. And gefitinib was taken off the market by the FDA when a large number of patients were on the drug and benefiting. And so the FDA allowed them to stay on the drug. And the drug company provided them the drug for free. And this is the time after they started. So most of these patients have already been on the drug for 1 to 3 years before this compassionate use study started. But you can see that many of these patients, this is 10 years. Okay, many of the patients who are still benefiting at 2 years are still benefiting at 10 years. Here at 15 years, almost half of the patients that went on this study were still getting the drug. So there are a group of patients who do exceedingly well. There's a larger group that doesn't do so well. So how can we identify those that are going to do well and those that aren't going to do well? The answer is we're not totally sure, but this was a study presented by Dara Eisner, who's a pathologist here, who looked at those patients who had an EGFR mutation without a p53 mutation and compared it to those that had an EGFR mutation and a p53 mutation. And you can see the presence of that tumor suppressor gene activation made the survival much worse. And so one of the things that we need to learn from next-gen sequencing is what is the role not only of the molecular driver, but also the other oncogenes in the tumor. What is their role? Now, in that same study, they looked at other drivers, and if you had 2 drivers, it didn't actually matter. So it was one tumor suppressor gene, p53, mattered, but the presence of 2 drivers didn't seem to matter. Okay, so about a quarter of patients will have a driver and get a pill. And what happens to those? So we're going to talk a little bit about something which we call here intrinsic resistance. And in the tissue culture sense, some people call that a persister state. Okay, if you're a cell kinetics person, you look at the log cell kill. Okay, we're also going to look at sanctuary sites, local recurrence, asymptomatic progression, and this clinical acquired resistance. So Skipper and Shavel, many years ago, when they were thinking about chemotherapy, wondered why chemotherapy didn't cure everyone. And so they determined that when you have a 2 centimeter or a mass in your lung, or anywhere else for that matter, you have about 1 kilogram of tumor. That's 10 to the 12th cancer cells make up a kilogram tumor. And if you give chemotherapy and get a partial response, you kill 90%. And if you have a complete response, you might kill 99%. Well, 90% is 1 log, and 99% is 2 logs. And so you don't cure the cancer. And so you give a round of chemotherapy, the patient gets sick, recovers, and you give another round. But there's always regrowth. And so they estimated that you might have to give 30 cycles of chemotherapy to cure somebody. And resistance was inevitable. Now, with these TKIs, it's completely different. We also kill 1 or 2 logs of cancer cells when we institute the treatment, and we killed them right away. But after 2 months, the tumor just sits there, and the CT scan doesn't change, and the tumor is just sitting there, not dividing, not growing, but sitting there waiting to get a resistance mutation when it can take off. So one of the questions, of course, and the question that we're trying to ask in the SPORE grant, and unfortunately a concept that pharmaceutical companies don't seem to get, and that concept is it would be better to kill more cells in the beginning than to wait until you get resistance and chase resistance. So this was a study from a few years ago where they just gave erlotinib to an EGFR mutant cell line, and a few cells persisted. And they called these persisters. If they added an HDAC inhibitor to erlotinib, there weren't any persisters. So a combination could kill more cells right from the start. And unfortunately, no pharmaceutical company has picked up on this concept, which is really what we need to do. Now, sometimes patients get worse in a single site. The most common single site, as we'll see in a minute, is the brain, but they might get worse in another site, and that's because the daughter cells are the ones that get the resistant mutation. And the daughter cells may be just in one metastasis and not the others. So sometimes people get worse in a single site. And this was a study where they looked at people who got worse in a single site. So when they got worse, that was the end of the progression-free survival. And in these 2 studies, there were some differences there. But if they just radiated the second site, the remission lasted longer. One of those studies was done here. Now, the most common single site is the brain. And the first generation drugs don't cross into the brain. So it wasn't surprising. But this is the frequency of failing in your brain if you have an EGFR mutation over time. And you can see by 3 years, half of the people have progressed in the brain in these various studies. So what do you do if the patient relapses in the brain? So the radiotherapists here and elsewhere, but they're particularly good at this here, give what they call stereotactic radiation. So they do three-dimensional radiation, delivering radiation in 3 dimensions to pinpoint lesions. But most patients don't have one. Most patients have more. So in this particular study, they looked at what happens if you relapsed in one brain site, or if you relapsed in 2 to 4, or 5 to 10. So the stereotactic radiation, you can aim it at 1, but you can also aim it at 2, you can aim it at up to 10. And if you radiated those up to 10, there was no difference in the outcome. Now, some patients relapse in multiple sites. The resistance mutation occurs in one of the earlier cells, and therefore it's in many cells. So this is what happens clinically. You have a big lesion, you get a 99% reduction, and it gets smaller, and the patient's feeling well. But then the cancer gets bigger. But when it's 1.3 centimeters, much smaller than the beginning, the patient may not be symptomatic, and it may be slowing the tumor down. So the question is, should you continue the treatment? These are people that switch treatments here, and these are people who switch treatment later, and it just shows you can stay on these pills and get some benefit for longer. And here's just a clinical example of that. Here's a patient who, when the tumor was like this, had symptoms. The patient got treated, the cancer shrunk both here and here, and the patient was feeling good. So 16 months later, the cancer was still responding, but 24 months later, the cancer began to grow. And later, I don't know what this was, 30 months, the cancer was a little bit bigger, but the person was still on the tyrosine kinase inhibitor. And the patient didn't get symptomatic and want to get treated till the cancer got to this size. So why do the cancers get resistant, and how do they get resistant? So here's our friend, the epidermal growth factor receptor, and here's our tyrosine kinase binding and preventing ATP. But cells are smart, and they get another mutation, and the new mutation prevents the drug from binding to that ATP binding site, so that ATP can outbind the first inhibitor. Well, drug companies can do this in 3 dimensions, and so they can make a new drug, a new TKI, that'll bind into a doubly mutated mutation site, and therefore block the signaling. Now in EGFR, we're kind of lucky because cells like to get one particular mutation to become resistant. And that mutation is at T790M. That's the amino acid change, the location of the amino acid change. And 60% of the people who progress on an EGFR TKI have that one mutation. And so the problem is to find that mutation, you have to do another biopsy. So what molecular pathologists like Dr. Franklin and Eisner and many others have been doing is to take circulating tumor DNA out of the blood and see if these mutations exist in the circulating tumor DNA. So this is a comparison from 2 different next-gen sequencing studies on either a tissue biopsy or the plasma. And you can see that the majority of time, 55%, they were in agreement. But they were often, and 27%, they were either 55% both positive, 27% both negative, but there were a large number of cases that were tissue positive but not plasma positive, and there was a relatively large number of patients who were plasma positive but not tissue positive. Now it turns out that the response to a drug was the same, whether the tissue was positive or whether the plasma was positive. So the tissue misses some, you put the needle in the wrong place, and the circulating tumor DNA misses sometimes because there's not enough tumor DNA. And so the algorithm that we use in the clinic now is you do what's called liquid biopsy. You collect circulating tumor DNA from the plasma, and if it's positive for this second mutation, you give the drug. If it's negative, you do a biopsy. If you do the tissue biopsy and it's positive, you give the drug, and if it's negative, you give chemotherapy. So these third generation EGFR tyrosine kinase inhibitors, like AZD9291 or osimertinib, not only do they bind to the T790 and to the original activating mutation, but they actually don't bind to wild-type receptor. And because they don't bind to wild-type receptor, they actually have far less side effects. So the EGFR TKIs cause skin rash and diarrhea, and those are uncommonly dose-limiting, and patients can continue, sometimes at a reduced dose. But these third-generation drugs have far less toxicity, and you can see if you have an EGFR T790M mutation, the majority of patients benefit. Okay, so Dr. Suda, here in the orange suit, wanted to know, theoretically, how could I improve the outcome from people with these molecular abnormalities? So one way is to figure out, well, maybe some of the cells have the resistant clone before you start. And so if you treated with a drug that hit the resistant clones as well as the original clones, maybe you'd do better. But maybe there are survival pathways that get activated in the presence of the drug, and these survival pathways allow the cells to survive in the presence of the drug. So if you inhibited these survival pathways, maybe you'd get a better effect. On the other hand, maybe the tumor microenvironment is helping the cells survive in the presence of the inhibitor. And maybe we should look at the microenvironment and see what's happening in the microenvironment to help out. And alternatively, it may be that blood supply and hypoxia account for the survival, and so if you inhibited blood perfusion, maybe you'd get a better effect. So if you have a drug that inhibits an activating mutation and T790M, what would happen if you gave it first? So you could kill the clone that's going to grow out and cause resistance. And so what would that look like? So here's the third generation drug. And this is the tumor shrinkage. And you can see if you give it first, almost everybody responds. And you can see that they respond for quite a long time. Remember, when we had those first slides, the median progression-free survival was about 8 or 10 months. And now if you gave this drug first, the median progression-free survival was 19 or 20 months. So maybe that was a good thing. And another thing is these third-generation drugs cross into the brain. And so they might also, besides killing the resistant clones, they might prevent relapse in a very common site, the brain. So which generation is better? So I don't have a slide of Trump, but fortunately, he's hopefully the first and last generation of, I guess I shouldn't talk about politics. So we have these randomized trials that compare the standard erlotinib or gefitinib to the new drug osimertinib. And next year, this year, 2017, study results will be known. The study results aren't known. It would be anticipated that if you got erlotinib or gefitinib, you'd go 10 months, and then you would switch to osimertinib and go another 10 months. So it might be 20 months until you get chemotherapy. And it would be anticipated that this drug would be 20 months straight away. but of course it wouldn't do any good to switch over. So the trial will likely show an advantage in progression-free survival. Question is, how clinically relevant will that be? And so this reminds us of our old days of tuberculosis. So bacteria are smart, and they make new mutations that cause resistance to the antibiotic. So drug companies were chasing resistance forever and ever, and they kept finding new resistance mutations. So these are studies looking at people who get second generation or third generation EGFR TKI, and what happens? They get a new mutation, and the new mutation prevents the binding of the new drug. So we can keep chasing resistance forever and ever, but we're not going to cure patients by chasing resistance. So let's go back. We talked about this one. What about this one or this one? So this was the only trial to date that's been presented. Others are ongoing, and this took erlotinib and added an anti-angiogenesis antibody called bevacizumab. And this was the progression-free survival of people that got erlotinib alone, and this erlotinib plus bevacizumab. So potentially, besides the T790M inhibitor providing more benefit, potentially an angiogenesis inhibitor could provide more benefit. So Dr. DeGregory, who introduced me, wanted to do synthetic lethal screens to determine those proteins or genes that would allow cells to survive in the presence of an EGFR TKI. So they took cancer cells and they exposed them, or didn't expose them, to the TKI, and then they knocked down the entire genome, silenced the entire genome, and saw which genes didn't show up in the survivor cells. And they found a number of genes, not surprisingly, that if they were knocked out, improved the efficacy of gefitinib. And some of those genes, shown here, were genes that were not found in the surviving cells, indicated that they increased the benefit of gefitinib. And many of them were in the Wnt beta-catenin pathway. And so the question is, if you knock down or used an inhibitor of something in the Wnt beta-catenin pathway, would it block the survival signal that was allowing the cells to survive in the presence of the TKI? And it turns out there's a number of drugs that inhibit different parts of the Wnt beta-catenin pathway. So some of them are involved in Wnt signaling, some in the receptor or even ligand receptor, and then some in the downstream pathway. And so many of the drug companies have made inhibitors of different parts of this pathway. The ones I'm going to show you the most on are IWP, a porcupine inhibitor, and AZ1366, a tankerase inhibitor. So Hannah Scarborough, and this paper's published now, I guess I should update this slide, did a study looking at the third generation EGFR TKI, gefitinib, the first generation and the third generation, and then added the tankerase inhibitor AZ1366. And you can see that the best cell kill by far was when you combined the tankerase inhibitor with the EGFR inhibitor, irrespective of which it was. And you can get what's called a CI value, a combination index value, and anything less than 1 is synergistic, but the lower the better. And you can see that there's numbers here like 0.07 and 0.18 that are very good combination index numbers. You can also see from another study that one of these porcupine inhibitors, IWP, also was synergistic with EGFR TKIs. And it wasn't just in cell culture, but it was also in animals. Here's a number of animals that were treated with gefitinib, and you can see that after time the tumor regrows. But when you give the tankerase inhibitor and gefitinib, the tumor grows much more slowly and delayed, and therefore the mice live longer. Now, if the mouse cell line that you start with has a T790M mutation, the results were not as impressive. And Dr. Tan and his colleagues, I don't know where AC is, there he is, looked at what happens to the surviving cells, these persisters that we saw wiped out in the beginning. So you don't kill every cell, so you can look at the gene expression of the few cells that survive. And you can see on different days after exposure to the tyrosine kinases, there's a lot of gene changes. Some of the gene changes that happen early persist, and some of them change later, but may persist for a long time. So one of the hypotheses has always been that epithelial cells have lots of properties that make them bind to one another and prevent them from metastasizing. And that sometimes cells lose that epithelial phenotype and change to a more mesenchymal phenotype and metastasize and spread much more and kill people. And there are many genes and proteins involved in this epithelial to mesenchymal transition, and that transition is not always the same, but two of the proteins that are involved are E-cadherin, and E-cadherin is an epithelial protein that keeps cells adhering to one another. And you can see that that is lost quite rapidly when cells are exposed to a TKI and stays down for a long time, whereas the mesenchymal marker goes up fairly early on and stays up for a very long time. And so that raises the question of killing these persisters with an HDAC. Is it preventing this epithelial to mesenchymal change? And there have been a number of studies with a number of HDACs that have shown synergy. So another question is, can you give two drugs safely to patients? So we did here a trial that was published some time ago in which patients were randomized to get atinostat, an HDAC, plus erlotinib or erlotinib alone. And not all these patients had an EGFR mutation. There were wild-type patients in here as well. But those that had high E-cadherin in the beginning, that were epithelial in the beginning, did much better with the combination than those that just got the EGFR TKI alone. Now, we don't know if those gene changes that Dr. Tan found in the cell lines happen in the person also. And we also don't know if the tumor microenvironment gene changes are affecting what's happening. And so Doctors McCoach and Doble here at Colorado have what's called an early rebiopsy protocol. So patients with an EGFR mutation get treated with the drug, and 2 weeks later they get rebiopsied to see if those same survival pathways are activated in patients as get activated in a cell culture or in a mouse. And you can see here's two patients who entered this, who 2 weeks later had shrinkage, but were able to get biopsies. Interestingly enough, a lot of times, though, patients respond so well that 2 weeks later there's nothing to rebiopsy. And so anyway, this protocol is ongoing, and we don't know the results to date. So the number of drivers is, of course, increasing. And so the number of patients who can get a molecular therapy is increasing, although the elephant in the room, KRAS, is still sitting here as the most common, for which we have no effective treatments at the moment. So just a couple words about one other molecular driver. This one is ALK. And ALK is activated not by a mutation, but by a rearrangement. So in a normal chromosome 2, you have the ALK gene, and then separated some distance away is another gene, in this case EML4. And so originally, Leila Garcia here put a red probe on the 3' end of ALK and a green probe on the 5' end. And so when you look under a microscope, this gene doesn't take up much room, and so the green and the red probe are right next to one another. But when you have a break in the chromosome and the gene gets rearranged, okay, so now that ALK is broken, one end is here and another end is over here, the green and the red become separated. So these are called break-apart probes, and the cytogeneticist looks at the distance between the red and the green to see if it's normal or whether there's this rearrangement. And so, not surprisingly, the drug companies made drugs that bind to ALK, and those drugs did better than chemotherapy if they were given second after chemotherapy or as the first treatment before chemotherapy. They did better and got approved. And then we got second-generation drugs, and in a minute I'll show you what the second-generation drugs do to the gatekeeper. But if you give a second-generation drug, such as alectinib, and you compare it to the first-generation drug, crizotinib, these second-generation drugs do better. Dr. Suda was right that if you kill the clones that have the resistance mutation, you'll do a little bit better. And then we have a whole bunch of second and third generation drugs. And the reason that this got a little more complicated was somewhat described by Dr. Doble here. And he looked at people who progressed on these tyrosine kinase inhibitors. Not surprisingly, the most common mode of resistance was a gatekeeper mutation that prevented the drug from binding, but also activation of other pathways occurred. And when people looked at those gatekeeper mutations that are, again, in a smaller pie, remember this piece of the pie for EGFR is about 60%. This piece of the pie here is only 30%. But that piece of the pie is way more complicated. The 60% for EGFR are all T790M. And look at the gatekeeper mutation sites for ALK. So you have single point mutations in multiple sites. And here's the first drug, crizotinib, okay? And you can see a lot of red here. So crizotinib didn't work in some of these patients because they had a gatekeeper mutation at the beginning. But here's the sensitivity for these various mutations of the new drugs. Okay, so you can see that if you get a mutation in this gatekeeper, G1202R, when you're on crizotinib is not going to work. If you switch to one of these drugs, it's not going to work. But if you switch to lorlatinib, you're going to get a response. And so the situation for ALK is a bit more complicated. Not only do you have to know if there's a gatekeeper, you have to know what the gatekeeper is to select the best drug. Now this is, if you remember Dr. Suda's slide, this is only those resistant clones. So we're still not talking about survival pathways, we're still not talking about angiogenesis and microenvironment. And one of the questions is, for ALK, are those survival pathways and those microenvironment changes the same as they are for EGFR, and we don't know the answer to that. So I have to talk about this because if you watch television, all you're going to see is ads for Opdivo that imply that lung cancer patients are being cured by this new wonder treatment. So this is the basic principle of the immunotherapies that we have at the moment, and that is when you have cells like lymphocytes. Well, first of all, you have a dendritic cell that presents an antigen on the MHC, and that's recognized by the T cell receptor on killer T cells, and that activates killer T cells to make gamma interferon and other things that kill cancer cells. But cancer cells don't like getting killed by lymphocytes, and so they make proteins like PDL1 that bind to proteins on T cells, and they prevent the activation of the T cell. So when PD1 on a tumor cell binds to PDL1 on a tumor cell binds to PD1 on a T cell, the T cell is inactivated. It's not secreting gamma interferon and cytokines, and so the tumor cell survives and it's not killed. So you could interfere with this pathway by making antibodies to PDL1 or to PD1. And of course, drug companies did both. So this is the most recent study. And in this study, the anti-PD1 antibody was called pembrolizumab, which we shortened for Pembro. And these were patients whose tumor have more than 50% of the tumor cells expressing PDL1. And that happens in about a quarter of the patients. So these are the patients who have high PDL1 or inhibiting the lymphocytes the most. So the question is, what would be better, giving this antibody that has toxicity, but much less toxicity than chemo? And this was the time until the cancer got worse. And the blue line, standard chemo, and this is the immunotherapy. So kind of looks like molecular therapy in a way. And this was the overall survival. And so people who got the Pembro lived significantly longer than people who got chemotherapy. And so the trial was stopped and the data have been presented, and the FDA has approved this antibody, pembrolizumab, for the first-line treatment of those patients whose tumor has very high expression, more than 50% of the cells, which is about a quarter of the patients. Now, most of the studies that were done didn't select patients based on their PD-L1 expression. They just took everybody. And most of the original studies were done after chemotherapy. So you got one chemotherapy and progressed, and then you were randomized to get one of these antibodies or to chemotherapy. And this one is the one you read about on TV. And here's the, quote, cure rate that you see on TV. Unfortunately, these lines are all going to zero, so despite TV, we don't probably cure very many people. But the blue line obviously was better than the green line and had less toxicity. And that was nivolumab, and here's pembrolizumab, and the same thing happened. Those that got the antibody at one of two different doses did much better than those that got chemotherapy. And if your cells, a lot of them expressed, the benefit was more than the fewer of them expressed. So there are 3 antibodies approved for the second-line treatment because they're better than chemotherapy. Now recently, this got a lot of publicity. So this was a study in which people, for their first treatment, were randomized to get chemotherapy alone or chemotherapy plus the checkpoint inhibitor. So this is a standard oncologic principle. If one is good, 2 must be better. One of the issues here, though, is that the chemotherapy kills lymphocytes, and you have to give steroids with the chemotherapy, and that kills more lymphocytes. So the question is, will this block the action of this? So in this study, the time until the patient got worse seemed to be better if you got chemo and the antibody compared to chemo by itself. Of course, you can give these things sequentially, and there was no difference in survival. And that's the same as most of the other early trials that weren't randomized. And the newspapers and the Wall Street investors would have you believe that giving chemotherapy with these is better, and this was submitted to the FDA, and that got a lot of publicity, but the FDA hasn't said what it's going to do. And another thing that you could do would be to combine two antibodies that interfere with the immune system. In this case, a PD-1 inhibitor and a CTLA-4 inhibitor. So in early trials, these were not randomized phase 3 trials, just early trials. This was the response in people who got nivolumab alone, and this was the response in people who got nivolumab plus the CTLA-4 inhibitor, ipilimumab. And this seemed better than this. And so what we have now is a whole bunch of randomized trials, this is just one of them, in which patients are determined their PDL status, and if they have PDL1, they're randomized to PD-1 inhibitor alone, PD-1 plus CTLA-4 inhibitor, or chemotherapy plus or chemotherapy alone. And if there's no PD-L1 expression, they're randomized to nivolumab plus chemo, nivolumab plus ipi, or chemo alone. Now, ultimately, the goal, of course, of treatment is to cure people. And if you only kill a couple of logs, it's probably easier to kill people who have fewer tumor cells in the beginning. And so this is a study that's about to start here for early stage patients who are going to have surgery. And what happens is they get these checkpoint inhibitors first, and then they go to surgery. And that will tell us how often we can make the tumor go away before surgery, and what are the factors that are associated with killing a lot of cells or having a lot of cells survive. And lastly, everything I've said up until now has been about squamous cell adenocarcinoma and nothing about small cell carcinoma. And the early studies with these checkpoint inhibitors in small cell carcinoma are also quite promising. The median time to progression is not way better than expected, but these are also of long duration. So if you give chemotherapy, almost nobody hasn't progressed by a year. So although the minority of people benefit, those that do benefit have very high benefit. So now, if anybody's awake, they can ask a question. Yeah, James.
So when they combine with chemo, are they treating with chemo continuously, or do they just default and switch to chemo?
No. So chemotherapy, of course, is given in cycles, generally every 3 weeks. Most of the time you get steroids for a few days around that. So you get 3 or 4 days of steroids and 1 day of chemo, but you get the antibody at the same time. 3 weeks later, you get them both over again. Now the antibodies have a long half-life, so 3 weeks later there's still some antibody left in the circulation, but the lymphocyte killing is basically going on for most of that 3 weeks as well.
It seems that one strategy would just be to do a one bulk, right? So basically have fewer cancer cells left there for the immune system, let the immune system recover, then come in with the checkpoint.
I would think, in my own opinion, that sequential therapy, if you were going to combine them, would be better. Because killing lymphocytes at the same time you're trying to stimulate them doesn't make a lot of sense. But there aren't any trials like that, to be honest with you. Yeah. Okay, so that's a good question. So, interestingly enough, the molecular altered tumors generally have a couple of interesting features. First is, more often they're in never smokers. Second of all, their mutation burden, the number of mutations in such a tumor is much lower. Now, that's not all the drivers. That's certainly EGFR and ALK. So it has been shown that smoking status affects the chance you're going to benefit, and so does mutation burden. So high mutation burden patients are more likely to benefit from immunotherapy. So in one of the second-line trials, they compared chemotherapy to a checkpoint inhibitor, atezolizumab, and atezolizumab won. But in that one study, they looked at EGFR mutations. And the patients with an EGFR mutation did better with chemotherapy than they did with the checkpoint inhibitor. So we think that the ones with the molecular drivers, especially those with low tumor burden and never smoking status, are far less likely to respond. Now, KRAS is different. KRAS is actually usually induced by smoking. And so patients with KRAS mutations are more likely to have high tumor burden as opposed to low tumor burden. And those studies suggest that people with KRAS will do better with immunotherapy than with chemotherapy. So most of these molecular drivers that have a TKI, the TKI is going to be way better than the immunotherapy, but ones with KRAS and others with high tumor burden are going to do better with the checkpoint inhibitor than with chemotherapy. Some people want to know if you, over time, what happens? Does PD-L1 status change? So if you progress and get one of these secondary mutations, will PD-L1 go up and maybe patients would be more sensitive to a checkpoint inhibitor later? And that's sort of in the sort of microenvironmental changes, and we're studying that in its infancy. Okay. If you want